Good now afternoon, everyone. We always really appreciate that folks come and spend their lunch hour with us learning about Dementia Care Aware and the topics we focus on related to dementia. Really excited to welcome everybody today to our topic this month. Of course, very relevant. It's a special day. It's an extra day in February this month, but of course, this month is African American History Month. And I think for Dementia Care Aware, this topic is particularly important. So today, the topic is dementia and the African American population. And we're incredibly fortunate to have two folks who are local to me, two assistant professors at the UCSF Memory and Aging Center who are faculty there, Dr. Tanisha Hill-Jarrett and Dr. Windon. I'm Anna Chodos. I'm the director of Dementia Care Aware overall and often your host for these webinars. So I'm going to start off again as a few more folks are joining us to talk about the program briefly, just to give you some orientation to the Dementia Care Aware program. So once again, these are our esteemed and expert speakers, and we're really lucky to have them today. I also just want to point out that hopefully they can do a little more introduction in terms of their roles in their work when we get to their part of the discussion. I'm going to moderate, so we'll have three of us speaking today. And while Drs. Windon and Hill-Jarrett are speaking, I'm going to be throughout noticing your comments, your chat, your Q&A. I'll be answering where I can, and at the end, we'll definitely come back for a Q&A session, and I will help moderate that. So I very enthusiastically encourage you to please ask your questions, leave your comments. We really appreciate the interaction with you guys as learners. Really briefly, Dr. Hill-Jarrett has one relevant financial disclosure here, just to note that. And then I already started mentioning our housekeeping around Q&A. We'll also, right towards the end, give you instructions on how to claim your continuing education or continuing medical education credits. We have all the recordings of our webinars up on our YouTube channel, and you can get to that from our website as well, which is sort of mentioned throughout the presentation, dementiacareaware.org. And we will have the webinar slides as well posted there. So just in case you happen to miss anything, get called away briefly, we look forward to seeing you again. A reminder too that you can reach us at our email address, and you can find more information about the program overall at our website listed down here. But as many of you know, our goal is really to improve the frequency and ability of all of us to do screening in primary care. And so here's what we have to support you. We have webinars, as you see today. We have folks participating in the interactive case conferences, and then we have online trainings as well, if after this there's more you want to learn and engage with our program materials. We also have short podcasts, and usually after a webinar, we're able to, in pretty quick succession, about a month, within the next month, we're able to record a podcast version of this. So you'll get to hear some of the information and perhaps a little more conversation about it afterwards as well. And then, of course, 9 to 5, Monday through Friday, we have our warm line available if you're in clinical care and want some support with dementia care, and especially our screening approach. This is our core module available online, and also with CME and CE credits. As we're talking about this really important topic, one thing we really encourage is how we can address the needs of all Californians, including African American Californians, people from other backgrounds as well, through screening, through a universal screening approach. And as many of you know, the approach we recommend is what is presented here, the cognitive health assessment. And this would be something you can incorporate into practice to screen folks 65 and older who don't otherwise have a dementia diagnosis or a serious life-limiting illness. And so if we're going to take the approach of screening in primary care, we hope that that sort of universal approach will mean more people get detected earlier or detected at all. And the 3 steps of the cognitive health assessment, again, it's really dealt with in depth in our core module, is to take a brief history, like a simple question of all your older adults annually. Example, do you have any changes to your memory we should discuss today? The other is to use a screening tool for both cognition and function, and we offer many examples of validated screening tools to use that are short, of course. And then the last piece, we really emphasize starting to work with patients around who's their care partner, who's in their life, who's a foundational support for them. And is there somebody like that, in documenting? So those are the 3 parts of the cognitive health assessment. Again, so much more information available on our website. Our live trainings, we have many partners. UC Irvine, Alzheimer's Association are wonderful groups to connect to get these trainings. And of course, you can find information about that and sign up on our website. But these often are more accessible than the online trainings for people with busy schedules and who don't have extra time after work to do more training. Today, we're going to review the disparities in Alzheimer's disease and dementia that impact African Americans, identify how social determinants and drivers of health drive disparities and are key to correcting disparities, and review the practical use of our DCA tools, the cognitive health assessment, to improve dementia care and help reduce disparities.
Thank you all for your time and attention this afternoon. Again, always an honor and a privilege to be in front of you speaking about very critical topics, and we very much appreciate the invitation to do so from Dr. Chodos. Next slide. So I'll kick us off. My name is Dr. Windon, by the way. I'm one of the behavioral neurologists at the UCSF Memory and Aging Center. As we talk about Alzheimer's and dementia and health disparities in the African American community, it's important for us to understand what are health disparities and really what drives them, so to speak. So to understand this, there's a graphic presented here explaining really what health disparities, what healthcare disparities are, and how they're driven actually by health inequities. So we know health disparities specifically refer to higher burdens of a particular illness, injury, disability that are experienced by one group compared to another. So you could say something, for example, like African American individuals have higher rates of hypertension compared to individuals who identify as white. We have healthcare disparities as well, which are differences between these groups in health coverage as well as access and quality of healthcare that they receive. And all of these things are driven by health inequities, which are these larger systemic differences in the health of different groups and communities that occupy unequal positions in society. Many of these health inequities are avoidable, but really require deliberate attention and need to be addressed. Next slide. So how does this tie into Alzheimer's disease? Well, from a standpoint of incidence and prevalence of Alzheimer's disease, we know that Alzheimer's disease is becoming more common. So the graph on the left is a figure showing the number of individuals with clinical Alzheimer's disease, age 65 and older. We have over 6 million individuals living with the condition currently. By 2060, we'll have over 13 million individuals in the United States living with clinical Alzheimer's disease causing dementia. So we're going to experience a significant increase in the number of individuals who are experiencing this condition. We also know, however, that our nation is becoming more diverse. So if you look at the figure on the right, this is U.S. Census Bureau data comparing 2 time points, 2010 compared to 2018. Those are the 2 columns aligned by each other. And then you also have a comparison between these 2 time points across different age groups. So on the far right, you see the 40 to 64-year-old range and the 65 and older year-old range. And what you see here is that between 2010, and 2018, you're seeing greater representation of diverse groups essentially within the column. That's why there's a larger proportion of different colors in each column. So we know that our nation is rapidly diversifying. In certain parts of our nation, California, for example, this is becoming readily apparent, and we actually will soon reach a point where individuals who identify as non-white or from diverse communities actually outnumber individuals who identify as white, particularly among groups 65 and older. Next slide. We know that there are disparities in the prevalence of Alzheimer's disease and dementia that already exist. The unfortunate thing is that we have made very little progress in eliminating these disparities. So we know specifically that clinical Alzheimer's dementia is more common among African American and Latino individuals, 2 times and 1.5 times respectively, compared to non-Latino white individuals. We also know that Black and Latino individuals have the highest incidence of clinical Alzheimer's disease. As I mentioned, there's no sign of progress in actually reduction of these disparities, unfortunately. So the chart or the table here, the graph, I should say, on the right is a graph. It's a couple of years old at this point, but it's research done by an individual who looked at the actual incidence of Alzheimer's disease, clinical Alzheimer's disease among different groups. And so you can see, obviously, as individuals get older, moving from left to right, there's a higher incidence rate of disease. But you see very clearly that depending on the ethnocultural identity of the group, there are significant differences in the incidence rate, with the highest rates of incidence being among individuals identifying as African American. This is the purple line, the lowest rates of incidence being among individuals identifying as Asian American. That's the black line. Next slide. So if you've noticed, I've been very particular with regards to using the term clinical Alzheimer's disease, clinical Alzheimer's dementia. Why is that the case? Well, it's important as we look at the disparities that we're faced with to understand what is actually driving the disparities. Is it actually the case that individuals who have higher rates of clinical dementia, African American, Latino individuals who have higher risk for clinical dementia, is it actually true that they all have Alzheimer's disease? And there's data to suggest that that actually may not be the case. When we think about Alzheimer's disease and dementia, it's really important to understand that when we use these terms, we're referring to very different processes specifically. So the term Alzheimer's disease, currently as it's used, specifically refers to a pathological diagnosis. Specifically, we're talking about the presence of tangles and plaques within the brain of an individual. You can see these here in the figure. These are just graphics of what they look like under the microscope. But when we say Alzheimer's disease, we're specifically talking about the presence of these tangles and plaques and the accompanying changes related to them. That is very different from somebody who, say, has dementia, but they actually have presence of something like Lewy bodies or arteriolosclerosis, where they've had essentially something like a thrombotic event or a hemorrhagic event. And so when we talk about individuals who have dementia, we have to start to separate out who actually has Alzheimer's dementia according to some of these pathological findings, and who actually has clinical dementia that we may think is Alzheimer's, but it is actually potentially being driven by other pathologies. One thing that we know for certain is that cerebrovascular pathology may actually disproportionately contribute to dementia among certain groups. Individuals who identify as African American, Latino, other groups who have a number of adverse social determinants of health that they face day in, day out. Things like systemic racism, things like lack of access to healthy foods, et cetera, et cetera. And so we have to be very particular and we have to be very specific about what is actually causing somebody's dementia, because in order to treat it most effectively, we're going to have to know with a certain level of detail what is the root cause. Next slide. Why is this important? Well, there's some research that has been done previously to actually suggest that among individuals who identify as African American, Latino, and other ethnocultural identities, the primary driving cause of their dementia may not actually be Alzheimer's in and of itself. So this is data from what is called the IDEAS study. IDEAS was a very large study across the United States, inclusive of Medicare beneficiaries, that basically was trying to understand in individuals who get a specialized PET scan to detect Alzheimer's pathology, does it actually affect clinical management? Does it actually make the doctor make better decisions based on kind of the diagnostic information they have available? What IDEAS did capture is that it's one of the largest collections of individuals who are from diverse backgrounds, from diverse ethnocultural identities, who have these in vivo, meaning while they're alive, biomarkers of Alzheimer's pathology. You can see here a distribution across the different ethnocultural identities in terms of sex distribution, education. You can also see comorbid medical conditions, though, and the fact that there are significant differences between the groups, specifically African American, Asian American, Latino individuals had higher rates of vascular comorbidities and risk factors, things like hypertension, diabetes. All of these things we know contribute towards your risk of cerebrovascular disease. We also found in this study that individuals who are African American and Latino more impaired in terms of dementia when they came into the study compared to other groups. If we click once more, what we'll see is that there was a logistic regression done to try to understand what is the association between identifying as African American, Latino, Asian American, and your likelihood of actually having a positive amyloid PET scan, actually having these Alzheimer's pathologies present while you're alive. And what we actually found was that individuals who were from these diverse backgrounds had lower odds of actually having Alzheimer's pathology per these biomarkers, which suggests that there is something else that is actually driving their cognitive impairment and driving their dementia that may not just be Alzheimer's pathology itself. Next slide. This is additional work that I personally have done looking at this ideas data and trying to understand, okay, if there's an association between being from a diverse ethnocultural background and maybe lower rates of amyloid pathology in the brain, what about your living environment? Is there an association between residing in a neighborhood where you are exposed to greater rates of poverty, violence, et cetera, and your rates of Alzheimer's pathology? And what we see here is actually individuals who live in the most disadvantaged neighborhoods where there's the least access to medical care, least access to healthy food, high rates of poverty, et cetera, they actually have lower odds of having Alzheimer's pathology in the brain. And so again, this reaffirms this idea of are individuals coming from diverse backgrounds, particularly our African American folks, they may actually have a very complex kind of pathology that is driving their cognitive impairment, where there is some contribution from Alzheimer's disease, there's potentially some contribution from cerebral vascular disease, there is potentially contribution from other types of pathology as well. This is the level of understanding that we have to get to if we are going to ultimately begin to eliminate some of the disparities that exist in terms of clinical rates of dementia. Next slide. So I mentioned that this ideas study was done. There was essentially a second rendition of ideas, which was called New Ideas, which sought to examine the same question of, in clinical dementia practices, if you give a clinical dementia specialist access to these advanced biomarkers for Alzheimer's, does it actually change their clinical management? New Ideas is different from Ideas in that there was actually a very intentional recruitment strategy that was used by New Ideas to try to find and try to include the most disadvantaged, the most underserved individuals from diverse backgrounds across the United States, with a particular focus on inclusion of African American and Latino individuals. And so what you see on the left here is the amyloid positivity rate, including the number of individuals. So about 65% of the entire sample was amyloid positive. If we click once, what we'll see is that if you separate this out by sex, females had a lower amyloid positivity rate compared to males, just barely. If you click again, when you look at non-white individuals, so individuals, or excuse me, when you look at non-Black, non-Latino individuals, so individuals who identified as anything other than Black and Latino, the rates of amyloid positivity are about 68%. There's not a significant difference between males and females. But on the far right in the 4 purple circles you see here, this is actually a further breakdown looking at, okay, for Black males, Black females, Latino females, Latino males, what are the actual rates of amyloid positivity? And again, we see here there are lower rates of amyloid positivity, lower rates of Alzheimer's pathology, potentially among African American and Latino individuals compared to other groups, according to New Ideas. So again, all of this reinforcing and driving home the point that when we think about all of the different things that can cause cognitive changes, when we talk about African American individuals, when we talk about Latino individuals, other groups of individuals, we have to be aware of the fact that there is potentially a complex kind of situation at hand where there are multiple pathologies that are essentially driving the impairment. We'll loop back at the end to why this matters and why such an emphasis on this. But at this point, we can go to the next slide, and I will turn things over to Dr. Hill-Jarrett to dive in a bit more.
Okay, thanks, Dr. Windon. Hi, everyone. My name is Dr. Tanisha Hill-Jarrett, and I'm a neuropsychologist at the UCSF Memory and Aging Center. When we start to think about what's contributing to racial and ethnic disparities, we know it's not just biological factors. And that's really where the social determinants of health come into play. I'm sure many of you are familiar, but these are the environmental and social conditions that we live, age, and work in. The figure on the right provides a good overview of the different components that are a part of this framework. And these are all things that shape our health, whether it be education, access to quality healthcare, experiences of stress and discrimination, et cetera. And what we see is that across a person's life course, differential access and exposure to these things is what shapes disparities and leads to differences in cognitive aging and incident dementia. And what we also see is that certain groups are more privileged and have more access to environments that promote brain health. Next slide. So this next figure is one that I really like, and I adapted it to fit within our understanding of brain health. Basically, if you think about that upstream versus downstream determinants of brain health, in that framework, the upstream determinants are typically thought of as features of the social environment that influence a person's behavior and ultimately their brain health. So those were the things that were shown in that graphic on the last slide. And what I and other people are suggesting is that we need to go even further upstream to look at actual structural and political determinants. So these are the policies and systems that are in place that actually have influence over our communities and our environments that we live in. Okay, next slide. And so I thought it would be really helpful to illustrate an example that's really relevant for Black Americans about how policy influences the social environment and actually may be a factor that contributes to disparities in dementia. So education is a really critical one for older Black Americans. So those who were school aged around the time of Brown versus Board of Education, that legislation was passed. They're about in their 70s or 80s currently. And so that legislation actually integrated public schools. And when you think about it, this was in, I think, 1954. That actually wasn't that long ago. And so what you see in this map is it reflects school segregation prior to the law being passed. And so what they had were these separate but equal laws, but the schools actually weren't equal. And essentially, a lot of the people that were in these schools, the Black Americans, had a high student to teacher ratio. They were largely under-resourced. And sometimes actually students had to leave school to go to work. So they were missing a lot of school. And what you notice is that a large majority of the schools that were segregated prior to the passage of this law come from the South. And so what a lot of people were really interested in is the impact of segregation, right? And then integration. What does this impact have on the quality of education and ultimately on brain health? So next slide. And this is important because we know that education is strongly linked to this concept of cognitive reserve. And so cognitive reserve is thought to be this buffer against underlying Alzheimer's disease pathology and other forms of neuropathology. So the thought is that, as shown in this image on the right, that two people can have the same level of underlying pathology, but the person with higher cognitive reserve will actually be able to withstand more pathology before they go on to develop clinical symptoms of dementia or cognitive impairment. Next slide. And so given these gross differences in education quality for Black Americans in the South compared to everywhere else in the United States, one, what does this mean for their cognitive reserve and their corresponding risk for Alzheimer's disease or other forms of dementia? And so what research, really seminal research by Jennifer Manley, who's a neuropsychologist at Columbia University, has shown is that it's really about literacy as well as the quality of education for the reasons that I've described in terms of different, like gross differences in the education system by region. And so traditionally, when we think about even in neuropsychology, we oftentimes assume that 12 years of education or a high school education means the same thing for everybody. And what her work has really shown is that it doesn't, and that it's really about the quality. And we also see that education quality explains a pretty significant portion of racial disparities in cognition. So next slide. And so to this previous point about cognitive reserve and it serving as a buffer, I, along with colleagues, collaborated with Justina Avila-Reiger, who's a postdoc at Columbia University, to actually examine this, to see whether or not education would differentially contribute to estimates of cognitive reserve across different racial and ethnic groups. And so the model that we used is shown there on the right. And initially, we just examined associations between pretty basic indicators of brain integrity. So looking at things like hippocampal volume, cortical thickness, white matter hyperintensities, and its association with cognition. We looked at language, memory, and I think some other, can't remember the other domains off top, but memory and language were the main ones. So we looked at baseline cognition as well as decline over time. And what we were interested in is whether the declines in brain integrity were buffered in the same way by education for Black, white, and Latino participants, with the thought being that maybe because of differences in education quality across groups, this buffer afforded by education would actually look different. And that's actually what we saw. And so what we saw was for Black and Latino participants, higher education, so higher levels of education actually did not buffer the impact of decreased brain integrity on memory or language declines. But we saw that education actually did buffer for white participants. Again, I think this goes back to the importance of looking not only at just the number of years of education, but also quality, which literacy is thought to be a proxy for that. Okay, next slide. So hopefully that study also just illustrates really the importance of policy, both present day policy, but also historically, particularly when we're thinking about the cognitive aging of older Black adults. These are some really good resources that have informed my thinking. And one of those actually was a collaboration with Paris Adkins Jackson, who's at Columbia University, where we start to think more about these upstream factors as well as the structural factors and their relationships to cognitive aging. Next slide. And then you can next hit. Yep. Okay. So when we start thinking about brain health, what goes into health, about 50% of brain health traces back to the person's home, physical environments, reflecting some of those social and structural factors that I've already discussed. But then you also see on the bottom that there's about 20% that's traced back to healthcare. I think that's pretty significant and pretty substantial and something that we as healthcare providers have more direct control over. And so in these next slides, I really want to explore that a little bit more. And so as was mentioned earlier by Dr. Windon, we know that Black Americans have about twofold the risk of Alzheimer's disease and related dementia, so other forms of underlying pathology. There's also diagnostic disparities that impact the care that they receive. And what we're seeing here in this image is that missed and delayed diagnosis is actually a pretty common thing across everyone, but it's even more common across racial and ethnic minorities. And what we see for Black Americans and Latinos is that clinically, they're often presenting later in the disease course with more advanced symptoms, which oftentimes as a clinician, it makes it challenging to intervene in ways that may slow the trajectory of cognitive decline. And so I really think the onus is on us as clinicians to do better at screening, recognizing symptoms, ensuring that they have the appropriate referral to specialty clinics and not getting kind of lost in the healthcare pipeline. Next slide. We also know that discrimination is a major factor that influences experiences within the healthcare system. And so these data are based on a survey from the Alzheimer's Association. And what we see is that 50% of Black Americans, which is pretty substantial, right, who are seeking care for dementia actually report that they've experienced discrimination of some form or another. Okay, go to the next slide. These are some other, I think, pretty relevant statistics. So 20% say they haven't experienced any barriers to healthcare, which means that a majority of people have. About half of them report being confident that they can actually access culturally competent care. And only half believe that a cure for Alzheimer's disease would be fairly distributed to them without, bias in terms of race, ethnicity, et cetera. And then when we think about caregivers or care partners, about 40% of them say that they faced discrimination when navigating healthcare systems. Okay, next slide. So I want to talk a little bit about one of my studies that was recently published that looks at whether experiences of discrimination actually shape interest in Alzheimer's disease predictive testing. And what we looked at was, it was a hypothetical test that potentially would be able to tell them whether or not they would go on to definitively develop Alzheimer's disease. And I think that this is important because we know that we're in an era of disease modifying therapies. And so we may actually not be too far from this possibility. Also, to really ensure equitable access, it's important to know what factors shape a person's desire for testing. And given some of the statistics that I've shared from the Alzheimer's Association, as well as, the history of medical experimentation on Black Americans and their experiences of racism within the healthcare system, I really think it's important to look at whether discrimination influences interest. Next slide. And so the way I did this was looking at data from the Health and Retirement Study. And so HRS, Health and Retirement Study, comes from the University of Michigan. It's a longitudinal panel study, and it surveys a sample of about 20,000 older adults in the United States. For my study in particular, we looked at about 1,500 adults who completed a survey either in 2010 or 2012. And at the time that they completed the survey, they were at least 51 years of age. And we looked at discrimination, and I'll talk a little bit more about the measures that were used, but we looked at different types of discrimination across racial and ethnic groups. And then they also answered a question about Alzheimer's disease predictive testing, which I'll talk about as well. Next slide. And so the first questionnaire was the Everyday Discrimination Scale, which was developed by David Williams at Harvard. And this is thought to get more at interpersonal, so person-to-person experiences of discrimination. The questions are shown there. The respondent would answer each question and rate how often they had that particular experience of discrimination. And then they were asked to select the reason why they thought that they experienced discrimination. So was it for because of race? Was it for age, et cetera? And we actually combined ancestry with race, even though they're technically distinct constructs, but for the purposes of analyses, we combined the two. And people were also allowed to select more than one reason. We transformed their responses. So we transformed it from Likert scale into a binary. So it was either, yes, I experienced discrimination based on their responses, or no. Next slide. And then this shows the lifetime discrimination questionnaire, which is thought to get more at structural level factors. And one of the questions, as you see, question 7, specifically asks about healthcare, which I think is really relevant. And I'll bring that back up whenever I talk about the results. They aren't asked why they experience discrimination, particularly at structural levels. It's hard to know why. But we also transformed this into a binary variable. Next slide. Okay, and so our outcome of interest was whether or not they would be interested in this predictive test. So they were asked if they could receive a test from their doctor free of charge that would definitively determine whether or not they would develop Alzheimer's disease. And people were randomly assigned into 2 different conditions, either sometime within the next 5 years or sometime within the future, do they want to be tested? We did a sensitivity analysis to compare whether there were differences across like the groups that were given different timeframes. And there wasn't, so we combined the 2 groups. Okay, next slide. And so this is just kind of a breakdown of the results. And so in terms of the demographic composition of the sample, so the mean age was about 67, and we can see that a majority of the sample were women, 40% were men, and a majority of the sample actually was white, about 66%. And about 3/4 of the sample had at least a high school education. And then we get a little bit further into the results, and we see that about 80% of participants, so that box that's highlighted, expressed interest in wanting Alzheimer's disease predictive testing. And then when we look at, okay, well, who were these people? We actually see that people who expressed interest were more likely to come from a racial or ethnic minority background. And so the lines that are in red, they were more likely to be Black or Latino. And then if you look at the 2 bottom lines in the table, we see that most people reported experiencing everyday discrimination in at least one domain, and a little less than a quarter experienced major lifetime. So major lifetime would be the structural in at least one domain. Okay, next slide. And so these are the main results. So we converted our findings from odds ratios to risk differences, just because it's inappropriate with that when the outcome of interest. So interest in Alzheimer's disease testing, it was a commonly endorsed. So people frequently said yes. So we had to convert it to risk differences. And so we compared people who reported experiencing discrimination as reflected in the dark green bars to those who didn't experience discrimination in the light green bars. And then we looked across each of the different racial and ethnic groups by the different questionnaires. So the everyday discrimination questionnaire and lifetime discrimination questionnaire. And actually, to our surprise, we found that the probability of wanting a predictive test was not associated with discrimination across any of the racial or ethnic groups. This was true for both everyday as well as lifetime discrimination. And this was looking across the entire questionnaire, but given my interest and given some of the statistics that I've shared, we also looked at healthcare discrimination too, and there was not a significant association. Next slide. We then looked at the probability of wanting a test for the everyday discrimination. So this is based on interpersonal, and we looked at it by reason that they selected for why they experienced discrimination. So discrimination based on race or ancestry, financial status, or gender. And again, we found that discrimination was not, and despite the type of discrimination, it was not associated with interest in Alzheimer's disease predictive testing. Okay, next slide. So kind of to summarize, most of the participants age 51 and older in the sample, about 80% of them expressed interest in having this predictive test. And despite experiences of the structural and everyday discrimination, Black and Latino participants were more likely to express interest in wanting a test. And what we saw was that this interest wasn't curtailed by experiences of discrimination. And I think that this is important because we know that in research studies and even in clinical settings, Black and Latino participants are significantly underrepresented, or they kind of get lost in the system. And there's oftentimes a certain level of blame that's placed on the individual as if they're not interested or they're not the ones that are doing something right. And but what we're seeing is actually that even in spite of some of these barriers that they may experience, there is interest. And so to me, this implicates more structural and systemic level barriers that impact access to these sort of settings and resources that they deserve.
Thanks so much, Dr. Hill-Jarrett, for that amazing discussion. So to round out our discussion for the afternoon, a couple of things to leave you with. So one is the idea that there are therapies that are coming down the pipeline. The pipeline that you see is really represented by the figure on the right side, which actually shows over 120 different therapies at different stages of development. These therapies are directed against different pathologies as well. We talked about differences in amyloid pathology and Alzheimer's pathology, as well as cerebrovascular disease, et cetera, et cetera. Inflammation plays a role. And so there is science that is rapidly advancing what we are going to be able to use in terms of treatment for folks. We know, however, that it's going to be critical to establish an early and accurate diagnosis. And if you remember some of the comments I made earlier about the level of specificity and detail that we have to have with regards to making our diagnoses, that's going to become all the more important. We're not going to be able to diagnose individuals with just general run-of-the-mill dementia any longer. We're going to have to become very specific with regards to how we diagnose folks. These therapies are really only effective. There are some available. They're really only effective when individuals are detected early and they're at the earliest stages of the condition. My suspicion is that as we move forward, we will continue to emphasize early detection. We have not yet been able to develop therapies that actually reverse and bring individuals back, so to speak. But the earlier we're able to detect, the more accurately we're able to detect, the faster we can implement a therapy and the faster we can actually start to make a difference and hopefully begin to address some of the disparities that exist currently. Next slide. So what does this look like practically? The figure here is a figure by Livingston et al. It was in the Lancet a couple of years ago. But what they show is that the risk of developing actual dementia, actually, obviously, a course of across the entire lifespan, you amount risk for dementia, but actually that about 40% of any single individual's risk for dementia is modifiable. And there are different points at which interventions can be made to modify the risk. So if you look here at late life, there are still actually interventions that can be made that reduce somebody's risk of going on to develop dementia. Stopping things like substance abuse, smoking, addressing depression, addressing social isolation, getting somebody more physically active. Air pollution is a little bit more challenging to address depending on where somebody lives, and then also controlling conditions like diabetes. Actually addressing each one of these can substantially lower somebody's risk of ultimately developing dementia. And where does DCA and CHA come into this? I'm glad you asked. If we go to the next slide, if you remember from a CHA standpoint, what you're doing is you're beginning by taking a brief patient history and really essentially obtaining more details about the level of cognitive impairment and what is actually occurring. You're using some of the screening tools that have been put forth and validated to detect cognitive impairment. And then you're documenting care partner information. So you're gathering a lot of information that is going to help identify individuals who are experiencing cognitive impairment, and even potentially help shed some light on what might be causing the cognitive impairment. But it goes beyond this. If we go to the next slide, what we know is that it doesn't just stop here. So after somebody has a positive health screen, you're going to actually take steps that are going to make a difference. If we click one more time, so you can see here, if somebody comes back with a positive screen, you're going to actually screen for depression and substance abuse. We just talked about how stopping smoking and addressing depression in late life can still lower somebody's risk of dementia. You're going to evaluate for other diseases. You're going to order a number of tests as well. And then you're going to transition to looking at function. So you're going to do functional assessments, try to figure out how you can kind of optimize somebody where they're living, and then also look at their support systems. If we click once more, again, all of these things that you're doing in terms of assessing somebody's function, assessing somebody's support system, and introducing interventions, you are actively reducing their risk potentially of further cognitive decline or going on to develop dementia if they're in something like a mild cognitive impairment stage. And again, we see this according to the Livingston diagram, where each step along the way in late life, you addressing things like depression, social isolation. If we click once more, I think physical activity will come up. All of these things you're doing as part of your CHA next steps from a positive screen are actively reducing somebody's risk of getting worse or going on to develop full clinical dementia if they have MCI. Next slide. So Dr. Hill-Jarrett and I are tremendously grateful for the opportunity to have been able to speak to you today. We hope that you learned something, and we are happy to open the floor for questions at this time.
Thank you so much. And efficient presenters. I don't know that we've ever had a better webinar. That was absolutely amazing. I learned so much, and I just really thank you both, because that was really interesting. I really, really appreciate it that you really went full circle. And at the second you guys started talking, I saw the diagram in my mind, and I think it really highlights the Lancet sort of path of modifiable risk factors. But just how much of that is structural. Like, I know some of the things like early education, just seeing also, your talk, Dr. Hill-Jarrett, really part of the talk really emphasized like how crucial that is. And I know as a geriatrician, I look at that risk factor and think, boy, I wish there was something policy-wise or system-wise that I could do to support better education for everyone. But anyway, I just really, really want to say thank you. I learned so much. One of the questions that did come up, and I'm wondering if, because it might be a little meatier, is meaty, like a meal, is how do we think about how these factors relate to stress? And is there any evidence on that? Like, sort of what is the mediating, or maybe pathophysiological mechanism that I think you did a really good job of explaining how it builds cognitive reserve, particularly the aspect of education. But do we think stress in getting that education, like someone tied it to, a lot of these folks were able to get perhaps, better or more, like had better access to education for parts of their life, but maybe it was really stressful. So anyway, just kind of throwing that general question out there.
Yeah, I think that that's a great question. I was just reading it as well. And I don't know if I mentioned in my introduction that some of my work focuses on Black women. And actually, there's a growing body of literature that is looking at Black women in education, like higher educational experiences, oftentimes being maybe the one of one in a setting or even in like a work environment where there's not that sort of social support or other people that might look like them. And that in and of itself is a stressor. So while to your point, education is good and protective in some ways, it may place people in environments that are also stressful. And so that can kind of, I don't want to say it negates it. I don't know that we fully know the relationship over time, but I think that that's definitely a factor for sure.
Almost to balance out that question, someone asked or sort of points out that affirmation from the clinician of their patient for their strengths and maintaining an encouraging approach could be very helpful relative to all these factors. And it makes me think, because we kind of ended with, what are we really going to do in the clinic? How are we going to start to do a better job? Basically, I think is really the charge that you guys are bringing to the table with all the information you gave us today. And I really like that idea that we would integrate a more strengths-based or positive approach to support our patients. And as we're addressing this, because I do think, I don't really bring it up on a patient level necessarily every time, but, emphasizing that they're higher risk can sometimes be kind of stressful, or, it doesn't always feel kindly. And I know, we have to do what we have to do, but I'm going to open it up to both of you as clinicians. Are there ways that you talk to your patients when you're addressing these issues? I know you're not often in a screening moment, but that sort of emphasizes the strengths-based approach.
I think it depends a lot on kind of the patient, so to speak. And so I really try to tailor to who's sitting in the front of me and kind of what they're telling me. There are some individuals who, even with the strengths-based approach, how do I say this, I guess politely? There are folks who have told me they don't want to be kind of patronized, with a strengths-based approach, where I've kind of tried to highlight, well, you have a lot of positives in that you have, a lot of education, you do all these other things. And yet the attention turns to, okay, I understand that, but I know something's wrong, and I want you to help me figure it out. And I want to focus on, so to speak, the deficits and the things that are missing. I have other individuals where it's the exact opposite, where there is a lot more emphasis on kind of the strengths, and it, I think, can be helpful for individuals leaving the visit. So I tailor it a bit to who's sitting in the front of me, but I think there is it's a worthwhile approach in with the right person.
I agree. And I'm also just thinking about the figure with the modifiable risk factors. If the patient's engaging in some of that, continuing to promote that, but also, given that I'm a psychologist, I'm also very interested in like individual level, like, psychological factors that are strengths based. And so one of the things, particularly with Black women, is the idea of gender racial identity centrality. And that really is looking at how important their Black womanhood is to their self-concept. And what other studies have shown is that actually it's a pretty good buffer against stress. And so I think that can kind of be extrapolated to other groups of people, and that if you have, a sense of pride and identity in who you are, and you're able to connect with other people that share that experience, then that also could be something worth leaning into as well.
I also just do a shout out and really appreciate you both for your work, because I think the other piece is concordance with your patient. Like I feel like, there's a big structural issue we face is just a lack of, Black and African American clinicians. And so I know that that's something that has certainly been highlighted in research. Colleagues I have here at the Division of Internal Medicine around the fact that language and cultural and racial concordance is so important to many patients. So I know I think about that as a structural issue, like needing to support the workforce and getting more folks in the workforce. who, can acknowledge patients' racial and cultural background from a place of like shared and mutual experience. I don't know, because Dr. Hill-Jarrett, your talk kept making me think, well, what are the things that I could be supporting on the structural level that would help, move brain health and recognition and appropriate care of people with dementia. So I don't know if you have anything to share, like policies or things that we could be working towards.
For me, at least what I'm trying to do, just even in my day to day, is what you've already said, like diversifying the workforce. I think that starts with trainees. I think that starts with like graduate school admissions, medical school admissions, offering opportunities for people to shadow you. I think it starts really early on so that once it funnels down to who are the actual healthcare providers, you have people, you have that concordance, or you have people that have like vested interest in underserved communities. I think that's, at least for me, that's what I'm trying to do.
I'm going to add another question here that came from the audience as well. Like we saw that depression is a modifiable risk factor later in life. Wondering if either of you also have additional context or information to bring around other types of what the person asked about emotional dysfunction. So things like PTSD. What do we know about if that increased the risk for Alzheimer's or other types of dementia?
Or yeah, I think the question of mood disturbance and emotional dysregulation and the saying of cognitive impairment, it's complicated. So there's research that suggests that untreated depression, untreated anxiety, does increase your risk of cognitive impairment later on in dementia. But it's a little bit more nuanced than that. And the reason I say that is because very often what we actually see is that we have individuals who come into clinic who have new onset, essentially, mood disorders. They'll have new onset depression. They'll have new onset anxiety. They'll have new onset kind of mood dysregulation syndromes that are not necessarily related to grieving or life changes, et cetera, et cetera. And a lot of times they're not actually viewed as a prodrome for something neurodegenerative, which oftentimes they are. So if somebody, for example, comes into your office who has new onset, really florid depression or anxiety, and they're over the age of 65, they've never had really depression, anxiety to begin with, and there's not a life event essentially kind of accounting for this, your red flags really should be going up in terms of this may actually be the beginning of a neurodegenerative condition. And we miss a lot of these individuals because, we just assume it's part of normal aging, or we're not being the most astute with regards to our history taking in terms of, their length of depression or anxiety, so to speak. And so it's a factor that it is modifiable and it is important to address. But I think you have to be very careful with how you address it and how you treat it. It absolutely warrants treatment, don't get me wrong, in every scenario, but you have to think a little bit beyond about what is it actually kind of, a symptom of, so to speak. What is actually maybe underneath the surface that isn't readily apparent.
Wonderful, thanks. Yeah, I know, again, another example of how, especially as people get into the age range of higher risk of dementia or neurodegenerative process occurring, like behavior might be the main symptom or one of these non-memory, non-learning, or non-language symptoms. Great, thank you. We've reached a magical moment, which is the CE is now, continuing education credits are now open. I'm sorry, that is an order of business. So I will just show a slide that people can use to claim CE, and there's information in the chat. I know that's not the most exciting part of the talk here, but want to make sure people get their credit. And let's see here. I think one other just last question we should address is your data, Charles. Someone had asked earlier in the talk if it was adjusted for age, and I guess just want to make sure to get back to that.
Yes, it is adjusted for age.
Okay.
I think the figure I presented may have been missing that line because I had some edits to the table, but it is adjusted for age. That's correct.
Great. But I'll give everybody an opportunity to just know that we are on social media, and so we advertise all of our talks and resources. And the reason I bring it up is we will put up there when we have your webinar online, and when we have things like the podcast conversation we'll have after this. And I just want to thank you both so much for spending the time today to talk to our group. And also, I know for me, just really help contextualize why it's so important that we think about early detection, and why also on a much bigger picture, we're thinking about ways to improve structural access to care, because it's, you know, I think all of us are really, really motivated by the social drivers and determinants of health, and the goals to improve care for African-American patients. So thank you so much.
Thank you.